Yeah, I find this quite a difficult subject to talk about, but I want to emphasise its importance to you. One of the reasons there isn't a great amount of evidence around it, but we do know that contrast is harmful. Declarations of interest, as always, are up there. Just so you understand, I do sit on guideline groups. I have sat on NICE. I chair the Renal Association's Guideline Committee, which is NICE accredited. So it's very important when we do all of this sort of work that we do declare our interests. Otherwise guidelines can be undermined. So I come down today from Leeds. We're very lucky there in terms of the city we have and the wonderful nature of the city and the way it's developing. I've been going around a number of other cities outside of London with my daughter looking at, thank you Chris, at universities, and I think we're pretty much blessed with a wonderful city centre and university as well. And the beauty of that is that the teaching hospital sits on the doorstep of the university, and we've now got a major push in terms of the university coming together with the Leeds Teaching Hospitals, which is the Leeds General Infirmary and the St James's University Hospital, to really try and push the agenda forward in terms of the quality of care that we provide for patients, the research agenda and the education agenda. Today's talk I'm going to look at the definitions of acute kidney injury, well, more in terms of contrast-induced acute kidney injury, the change of terminology. It's down as contrast-induced nephropathy, but that term is somewhat historical, although most of the data is around contrast-induced nephropathy as it was defined. Talk a bit about the pathophysiology, prevention, and then the guidelines that we have. And there's a number of different guidelines, but essentially they come together to say the same thing. So why is contrast-induced acute kidney injury important? Why should you be interested in this, this particular subject? Well, it's important in terms of, firstly, the outcomes. We know that patients who develop acute kidney injury have worse outcomes compared to patients that don't, and I'm sure you've heard lots about that already in terms of length of stay, risk of death, risk of chronic kidney disease. This is now in the public domain. They know about this, and you're going to start seeing patients asking more about what are their risks around acute kidney injury as we develop that program, and therefore they're going to want to know about what is their risk if they're in hospital in terms of receiving potentially contrast, and the risk of death increases. This is a slide from McCullough's paper, and that demonstrates a big increase in mortality as the serum creatinine rises in a patient having received iodinated contrast media. We also need to be aware of this, and I think you all know this because you'll see it on the front line. 25% of our general population is now over 60. The 85-year age group will double in the next 20 years. 37% rise in admissions over the last 10 years to our front door. 66% of patients admitted are over 65 years of age now. 25% of patients have dementia. How do they look after their own fluid needs in the community or whilst they're in the hospital undergoing a series of complex interventions and procedures potentially? And patients greater than 85 will account for 22% of the bed days in the NHS. And this is the group of patients we're looking after. So, therefore, they have more comorbidities. They have more complex management issues. They have decreased functional reserve, cardiac, respiratory, and of course kidney, and we need to be aware of that in terms of their kidney function reducing. And remember, contrast is removed through the kidneys, as are a number of other drugs and medications. And this is often overlooked. A simple thing, but I think the bedrock, the foundation of good management for all patients, and something we need to instill into all education programs across all healthcare professionals. There's polypharmacy, and hopefully e-prescribing will help somewhat with this. Although I heard the other day that one e-prescribing system in one particular institution has switched off its alerts because there's too many alerts coming out for people to deal with them. So there's something there about when we're doing this sort of work, let's do it and maybe have a hit list of a few things that are important rather than absolutely satisfying everyone's own individual concerns. So this is the Royal College of Radiologists. The use of intravascular contrast agents has increased dramatically in recent years, and this is from the draft standards document that I've been working on with the Royal College of Radiologists, and I'll touch on that as we go through. The definition was of contrast-induced nephropathy, or SIN, of acute renal failure, the old term, secondary to intravascular iodinated contrast media, and it was then an increase in creatinine by 44 micromolars, which equates to the 0.5 milligrams per deciliter that the Americans use, or an increase of at least 25% from the baseline creatinine. So all these old studies are based on this definition of acute kidney injury following contrast. It's been described clinically as something that occurs within 3 days of receiving the contrast, usually non-oliguric, so don't be fooled by the fact that your patient is still passing urine. Watch out for their rise in creatinine. It peaks over 4 to 5 days and recovery to baseline by 7 to 10 days. The differential diagnosis includes other conditions and can be difficult to differentiate, and recovery is less likely if you have atheroembolism occurring. So the epidemiology of SIN, as it was called, following percutaneous coronary intervention ranges from 1 to 20%, depending on the population studies. The incidence increases following emergency PCI in patients. I think that's the thing here to focus on, is vulnerable patients are at the higher risk. So the message I want to get out from this is that it's acutely ill patients, vulnerable patients are the ones who are at risk of having damage to their kidneys from contrast. It's associated with poorer outcomes, even in patients with normal baseline kidney function, so it's not to be overlooked in those patients also. So the new definition came through from KDIGO, contrast-induced acute kidney injury. And that's a term that's now being taken up, and the new standards document from the Royal College of Radiologists has adopted that term. So what's the pathophysiology? Well, as far as we understand, the contrast media which is removed through the kidney, so it's filtered through, has direct toxicity. It provides an osmotic load which will increase oxygen consumption and increase blood viscosity, and then has an effect on adenosine endothelin such that you get a vasoconstriction as it downregulates nitric oxide and prostaglandins. So with this increase in free radicals and decrease in antioxidants, you get an injury on the kidneys. This would be something else that can happen, and you may have seen these sorts of cases. I have. This isn't contrast-induced acute kidney injury. This would be different. This would be related to the procedure whereby atheroemboli have been thrown off. So as I said, contrast-induced acute kidney injury, you usually do recover from it. In terms of your creatinine rise and fall, that's not to say there hasn't been some injury that isn't being quantified by that creatinine, and we touched on subclinical acute kidney injury at the end of the presentation. And this would be the classic biopsy in that patient who's not recovered, having had some contrast of cholesterol embolization. The cholesterol clefts are there because the cholesterol has been dissolved out during the processing of the biopsy. So we think about prevention. So simple things again. This underpins so much that we do in medicine and is so often overlooked because we look at the more intricate things, the more complicated things that are going on with patients. Let's evaluate the risk factors. Let's consider whether the study is actually appropriate. Consider the type of contrast agent that's being used, the dose of the contrast, and ensure that adequate hydration, that will be water, so hydration is to do with water, nothing else, or volume expansion, which will be to do with 0.9% sodium chloride or bicarbonate that you use to expand the volume, and avoiding nephrotoxic medications, or potentially nephrotoxic medications. I think we've got to be careful with our language here. ACE inhibitors and ARBs are very, very good drugs, and if we start telling patients they're nephrotoxic, then they might start to wonder why they're taking them and why they're holding them and should they restart them again, and yet we know they're very important. So I think we need to use language such as potentially nephrotoxic in this context so they can understand there's a vulnerability at certain times when the kidneys may not favour them being ingested and metabolised. So what are the risk factors? So we'll sort of step through these as our recognised risk factors, and then we'll see what the guidelines say as we work through the presentation. So non-modifiable, age greater than 75, it's a bit arbitrary, but people are living longer. And why greater than 75? Purely because the EGFR is falling in this age group and therefore be less able to remove the contrast and probably have other comorbidities associated with them. So it's a highlight, it's something there, let's think about this patient. Chronic kidney disease, an EGFR of less than 40, it used to be 60. But certainly NICE guidance came out and went for a 40 cut-off because I think it would be quite difficult to consider every patient with an EGFR less than 60. Obviously, if they're greater than 75, we'd consider within the group with other diseases, but we've gone for EGFR as an isolated value that you'd be concerned about administering contrast in a patient. Acute kidney injury, any patient obviously who's got acute kidney injury in terms of their ability to remove the contrast and therefore the effects it may be having on the patient. Liver disease and cardiac failure, we can't really modify those things too well. Modifiable, the nephrotoxic drugs, the potentially nephrotoxic drugs. Sepsis, hypovolemia. Intraarterial is thought to perhaps be of a higher risk than intravenous administration. High dose, multiple contrast studies, and then the type of contrast media. So, iodinated contrast media. The terms are a little bit confusing, but just to define them for you. High osmolality, is 1,000 to 1,800 milliosmoles per kilogram. Probably very unlikely to see this used in the developed world. Low osmolality or non-ionic monomeric, 600 to 800 milliosmolar, although still much higher than certainly your serum osmolality. And then isoosmolar, non-ionic dimeric forms, only one type that I'm aware of still at the moment, 290 milliosmoles per kilogram. So this paper, I've just picked out a few papers I think have affected the way or influenced the way that we consider contrast, and there's a real dearth of evidence base around this. And I should have got my slide out that NICE shows in terms of randomized controlled studies on renal disease compared to cardiovascular disease and gastro disease, and we pretty much flatline along the bottom in terms of the number of studies that we've got out there to base much of our practice. So a lot of it is around consensus of opinion around some papers that are out there, and we saw this as we went through the NICE guidance. NICE guidance costs about £250,000 to run a whole guidance for a couple of years. There's a lot of money invested in it. They do a lot of literature searches, and they look at the papers and they tear some of the papers to pieces. Papers that you might think are good papers and would influence what you're doing are then taken to pieces by the experts, and we're left with not a lot. So this particular paper, New England Journal of Medicine, looked at iodixonol, which is the only isoosmolar agent that I'm aware of at the moment, and it was shown to be beneficial in patients with diabetes and chronic kidney disease. And in that era they were describing chronic disease, not kidney disease, not by EGFR as we now know it well, but as a creatinine of 132 to 308 micromoles per litre. So again, a bit shaky in terms of definitions there. And they looked at the incidence of contrast-induced nephropathy between patients who received either Dixonol or iohexol for angiography. And the rate was much lower in those patients who got the isoosmolar agent as opposed to the low osmolar agent. So there was some evidence coming out there that this would be an agent that would be favoured. What about volume expansion? Hemodynamic effects of volume expansion, that would be your 0.9% sodium chloride or your sodium bicarbonate isotonic solution, would increase renal blood flow, increase medullary blood flow, and then would try and have effects there locally. Essentially, you'd have tubular pressure effects would also occur, and these effects can act to dilute the contrast media in terms of the amount of fluids. So if you're pushing fluids into the patient, you're going to dilute the contrast and reduce its toxicity, and also decrease its viscosity as it passes through the kidney. So this is a paper by Solomon, New England Journal of Medicine, 1994. And I was always aghast at this paper of 78 patients. So a New England Journal publication with just 78 patients. Patients had a mean creatinine of 186, and they received IV 0.45% sodium chloride, 1 ml per kilogram per hour, 12 hours pre and post angiography. And it was demonstrated you got better protection by using this fluid than given alone, rather than being given with furosemide or mannitol. So when I was a trainee practicing in Leicester, quite often we would be giving patients furosemide with their diuretics, because furosemide with their fluids, because we thought it was the right thing to do. This paper came out and it stopped us from doing that, but it's just 78 patients, and it's really had a big influence in terms of Solomon's career and also what we do in practice. This paper came out in 2002, and this was a larger number of patients, of 1,620 patients, 20% with mild chronic kidney disease. Mild, not quite sure what the definition of mild is. And they received 0.9% saline, and that was found to be superior to 0.45% saline. So hence we started to move from Solomon's recommendation of 0.45% saline to the 0.9% sodium chloride. And then Merton's paper came out, randomized control trial in JAMA, small number of patients yet again. So we can see that we really are lacking large numbers of patients to base a lot of what we do on. And this demonstrated that 0.9% sodium chloride versus isotonic bicarbonate with that pre-procedure infusion led to a much lower rate of contrast-induced nephropathy, as defined, as I told you at the beginning, of 2% compared to 14% with those who got 0.9% saline. And they thought perhaps it was through protection from oxidant injury through alterations of the pH in the urine itself. So, not a lot of data, as you can see, and you can see why I find this quite a hard talk to deliver in terms of the evidence base around it. So, what about pharmacological prevention of contrast-induced AKI? Because people like to use therapies, they like to use drugs to try and treat things, and we don't have drugs, we get a bit frustrated. So, phenoldiprine Selective dopamine 1 receptor agonist, increases cortical and medullary blood flow, so it's sounding good. I like the way it's working. Lots of work in models to start with. 6 times more potent than dopamine that our cardiac surgeons use and continue to use to great effect, and still puzzles me why they are still using it. And this increases GFR and increases the diuresis. It's administered intravenously. Therefore, it's something that's not easily given to patients, and there's a risk of hypotension and needs very regular monitoring. And up to the point of this slide set, there were 2 conflicting studies, and certainly NICE advocated that you wouldn't be using phenylnapine as anything that was useful for preventing contrast-induced acute kidney injury. But just so you know, because people will start throwing out, it's the people that have a little bit of knowledge that will start telling you you've got to use this or you've got to use that, because they actually don't really know the evidence. So you can just say back to them after this talk that you do know what the evidence is and you know the important, simple things that you can do, and you can just discount the other things that they recommend that you might try and use because there's no evidence behind them at all. N-acetylcysteine, so this was TEPL, so this was another New England Journal of Medicine publication. You can see that they're really thirsty for renal publications. They really want to get something here. 83 patients in this study, mean creatinine 216, 30% had diabetes. They had CT and they got a low osmolality contrast media. And they got the N-acetylcysteine, and the contrast-induced nephropathy in this very small number of patients was only 2% in the population that got N-acetylcysteine versus 21% with minimal side effects. So this was the seminal study in 2000 which set the pace for a whole range of studies on N-acetylcysteine and confusion around the topic. So why might it work? Well, there's theory behind N-acetylcysteine, and we know that it works certainly as something in patients who had overdoses in terms of protecting the liver. So it's definitely very good, and it's licensed for that. It's not licensed for protection versus contrast-induced acute kidney injury, and you need to let patients know if you're going to be using it, because it's not licensed to protect them. And just say they had that allergic reaction, which is very, very rare, it'd be a little bit of difficulty, I think, to explain that one. And it's not recommended by NICE either. So it induces glutathione protection, has a role in cellular defense, inactivates hydroxy radicals, stabilizes nitric oxide, and ameliorates renal vasoconstriction. So it has some physiology behind how it might work, and we really, really wanted this to work. I really, really wanted to work, and I bought in a load of stock for the hospital in the early days because I really thought it was going to be something we should use. But then I got a whole lot of discussions with Tony Nicholson, who then became the Pro-Dean of Faculty for the Radiology College, and he was really, really against it. And I'm glad I listened to him, actually, and we didn't use it. So I've heard occasionally that the cardiologists have used it, or maybe another colleague has used it elsewhere in the hospital, and that's without evidence. Panu in Kidney International 2004 came out with a meta-analysis of 15 studies. So we've got to the point now where there's so many different meta-analyses and reviews on it around very, very small numbers of patient studies. And she essentially, when she went through all of this, said that the benefit was of borderline statistical significance, and that was back in 2004. The ACT trial came out in 2011 in Circulation and really put the final nail in the coffin for N-acetylcysteine, which demonstrated there was no beneficial effect on the incidence of contrast-induced nephropathy in a large patient group. What about haemofiltration? We do see this practice and excitement about putting patients onto renal replacement therapy when a patient's got contrast. Well, this paper was performed in, again, it was published in the New England Journal of Medicine in 2003, had 114 patients, creatinine clearance of 26. These patients had had coronary interventions and they received a large volume. So a large volume, remember, they need that large volume. So think about how else can you prevent this injury occurring to a patient. They had haemofiltration 4 to 8 hours pre and then 18 to 24 hours post the procedure versus, well, it says hydration, that's what's in the text, but that isn't hydration, that's normal saline, that's volume expansion. And they saw a decrease in the incidence of contrast-induced nephropathy for 5% versus 50% that didn't receive haemofiltration. A decrease in hospital events, 9% versus 52%, decrease in hospital mortality, 2% versus 14%, and a decrease in one-year mortality of 10% versus 30%. So, points to consider around this study. Haemofiltration lowers creatinine concentration anyway, so you're going to see less contrast-induced acute kidney injury just because you're removing the creatinine. So that was a confounder. No information regarding atheroembolism in these patients. The use of heparin does have an anti-inflammatory role. These patients were on ICU where there's a 1-to-1 nursing ratio as opposed to the ward where we know that doesn't exist. There were the logistics of having to try and do this in the future. It's just not something that we'd be able to do. I don't think there's evidence to support its use anyway. These were very high-risk patients with multiple interventions, and they treated patients with a higher baseline creatinine. They experienced the greatest positive effect in terms of their long-term survival. So what about the avoidance of nephrotoxins? So there's some obvious ones that we all know about, but we still need to make sure that our trainees know about these drugs, because I still see patients receiving large doses of gentamicin when perhaps they shouldn't receive them. Now, I know you can say that gentamicin as a one-off dose isn't particularly harmful to a patient, and it's more than multiple doses that the evidence is based on, and it has that damage to the proximal tubule, but I still wouldn't be in favour of receiving some gentamicin if I was acutely unwell and was going to get some contrast as well, regardless of what others might say around it. Amphotericin B, there are lipid formulations which are preferred, which reduce the toxicity to the kidney, but these may be patients on the ICU that are on CVVHD or CVVH and have a fungal infection are on this, and then you're going to send them for a contrast study as well. So you need to think of the cumulative effects on a patient whenever you're organising one of these scans. Non-steroidal anti-inflammatory drugs are very, very obvious. And you've got potential nephrotoxic medications. So we have the ACE inhibitors, and the role of those is uncertain, and the evidence from NICE also demonstrated we couldn't go one way or the other way in terms of what we could recommend. So guidelines. Can we pull this all together with our guidelines? So we have the Renal Association, British Cardiology Interventional Society, and the Royal College of Radiologists. So we put together a joint guideline, which is published on the website, the renal.org website. Just to let you know, the website is being updated, and the guidelines will be produced in an HTML format. And I've seen the draft format of how that is. So you have a menu down the side, and you can dip into the document alongside, because trainees told me they don't like the way that the PDFs are set up as guidance, because you have to scroll all the way down and scroll all the way back up again. So I've listened, and we've managed to get Bruce Hendry to fund this change in the way that they will be produced on the website going forward. So keep your eyes open. It's quite hard work at the moment trying to coordinate this sort of thing, but the new guidance as it comes out will be in this format and easier for you to dip in and out, a bit like the UpToDate if you use the UpToDate electronic resource. Then we've got the NICE acute kidney injury contrast, acute kidney injury clinical guidance 169, which came out last year, which has a section on contrast-reduced acute kidney injury. And then I can share with the draft we've got so far for the Royal College of Radiologists that I've been contributing to. So the Renal Association website, just to point out, we are NICE accredited. The accreditation is up for renewal next year, so that could be quite hard to maintain. They're making their conditions more stringent, and I'll have to see what I can manage to do. In terms of there should have been a I see, okay. This slide doesn't come out exactly. To the side panel, you've got a panel of the different guidelines, and it has on their joint guidelines. So that was going to highlight this particular joint guideline that's up there. So this was the guideline we put together before the NICE guidance. And I haven't put all the different guideline statements in because they're a little bit repetitive, and I think I've emphasised the importance of your early assessment, and we're also going to dip into the NICE guidance on this. So I put up there guideline 3.1. So we suggest the unenhanced scanning or alternative imaging techniques should be considered in patients with risk factors for developing. So therefore, you need to think when any specialty comes up to you and says, I need a contrast study, and you need to think about, well, hold on a minute, do you actually need it? Because they won't necessarily be the ones that know about the risks around this. You're the person that will need to say to them, well, have you just thought for a minute, have you consulted the guidelines in terms of administering contrast? Is there another study that we can use? Or perhaps we could use less contrast, or perhaps in some centres we could use some carbon dioxide as an imaging tool. Some centres can do that, certainly Leeds we can do that to image instead of using iodonated contrast. MRI might be an alternative. So we recommend intravenous volume expansion with 0.9% sodium chloride or isotonic sodium bicarbonate in patients with high risk of contrast-induced AKI. So they're the two fluids we would recommend. We'd recommend there's no convincing benefit for prescribing oral or intravenous N-acetylcysteine or any other pharmacological agent to prevent contrast-induced AKI. All right, so those guidelines are out there, so if anyone's telling you anything different, you need to take them to those guidelines. And failing you going to the Renal Association guidelines, you should go to the NICE guidelines, and they were published in 2013. This was the headline that came out on the day that they were published in the Daily Mail. This was not really, sort of focused on what we just done. However, it's interesting that people are picking up now on fluids and hydration and dehydration, and my trust has got very keen on doing this, such that we want to have a major education push on top of everything I was doing myself at a local level. We've now got this to a stage where the Chief Medical Officer and the Patient Safety Medical Director wants to do something very significant. And we've just had an Ombudsman's report I've had to complete on how we're educating the medics around hydration and the management of patients in terms of intravenous fluid. So there was a case, as you can tell from what I've just said, where the patient did actually not receive enough water in our own hospital. So I don't think there's thousands that it's happening to, but there are some patients where they're still not getting enough water, which I thought was something that only really happened in the desert. So let's think about the risk of contrast-induced acute kidney injury in terms of what NICE put out there. So let's pull it together. So assessing risk factors in adults having iodinated contrast. EGFR must be checked within 3 months. Yep, so you can make that statement. You can link that in with your other professionals in your hospital. Be aware of the risk factors, so they need to be aware of those, and discuss the risk with patients. Okay. So we've got to think about that. Have we got patient information leaflets on that? Don't want too many patient information leaflets on stuff because it just overwhelms them, but there's something there we need to let them know about. Ensure the risk assessment does not delay the emergency imaging, so that's really important. So we want to get on with something, just get on with it, and you can write in the notes as to why you've had to do that, because if you delay the study, the patient would come to harm. So what are the risk factors that NICE agree with? Age greater than 75, greater or equal to 75, EGFR less than 40, heart failure, kidney transplant, hypovolemia, increasing volume of contrast agent, intraarterial administration of contrast agent. Doesn't say acute kidney injury. Whoops. Didn't notice that. In the NICE documents, I mean, not on my slide. I looked at my slide and thought I'd maybe cut and paste it incorrectly, but no, couldn't see it. Preventing contrast acute kidney injury. Offer IV volume expansion to adults having iodinated contrast agents if there are increased risk of the injury because of the risk factors that we've just demonstrated and gone through, or they have an acute illness, and offer either the bicarbonate or the 0.9% sodium chloride. So yeah, lots of guidelines, too many maybe, but these guidelines are coming together and agreeing, so there is some consensus there. Consider temporarily stopping ACE inhibitors or ARBs in adults having iodinated contrast if they have chronic kidney disease with an EGFR less than 40. So consider. It's not saying for everyone, it may not be the right thing to do, and I would say, why is the patient on the ACE inhibitor? If it's a heart failure, I've got a problem with stopping that in a patient. If it's purely for hypertension, then I might consider it. So just think of the indication for the ACE inhibitor in the first place. And then when do you refer to nephrology? Because we don't want to be referred every patient. We want every patient coming through to us because we're really struggling at the moment with the amount of calls we're getting around acute kidney injury from primary and secondary care. I can't even speak to my own registrar sometimes because they're on the phone all the time, it would seem. So there is something we need to push out in terms of when is it appropriate? When do you do your own piece of work? At what point do you call us? Renal is now, I've heard, the most unpopular specialty to come into for trainees. So it's something we need to think about this. I can't believe it. People are looking at each other, but that's what we've been told at the Renal Association. So we need to try and reinvigorate enthusiasm around this particular area and tell people it is something that's worth coming into, and they won't be inundated with calls around acute kidney injury all the time. And I'm a believer. I'm passionate about acute kidney injury, but there's a limit to how much we can manage. So discuss care with a nephrology team before offering the iodinated contrast agent to fluids who have contraindications to IV fluids, if they're at increased risk, they have the acute illness, or they're on renal replacement therapy. So what are the Royal College of Radiologists putting together? Well, I've just put this is a draft, okay, so this isn't the one that's come out yet. It accepts the term of contrast-induced acute kidney injury, so there's a sharing there, a common language that's coming across. It recognises that all contrast agents are nephrotoxic in the presence of reduced kidney function. Non-emergency patients need their EGFR available within 3 months, okay, some consistency coming across there in terms of the different guidance. Acute illness or CKD, creatinine within 7 days, which seems very sensible. Some other departments I've heard are doing point-of-care creatinines. So that is something that they're doing individually in a department. Just remember that doesn't go onto the results server necessarily. Doesn't mean it's linked in. So we might miss some patients there in terms of what's going on. So find out what's going on in your department, because it may well be that you've already got your radiologist doing such a thing, point-of-care testing. And that won't go into our large database that we hope to have in the future of all patients who've got acute kidney injury. What about gadolinium-based contrast agents? I didn't have this in the last time I spoke at the Academy, so decided to add this in because I think this is something that we're faced with, that discussion, that consideration. So I put this in. As I said, this is draft. Administration in patients with severely reduced kidney function rarely results in nephrogenic systemic fibrosis. And that's that condition. I've never seen it. Anybody seen it yet? Yeah? Chris has seen it. Anybody else? No. Yeah, over at the back. Okay, so sounds horrible. Deposition of connective tissue in skin resulting in joint contractures and other organ systems. So a horrible, horrible thing if it happens. And the college is stating that it can happen up to many years post-exposure. So we need to be very, very aware of this. Okay, again, because in our society now, people will spot these things. I got a letter from a patient the other day who, from 2011, something happened with another doctor, and then they found out the consequences of this and what it meant to them, and now got their MP on their side around this case. So I just warn you that you need to think of all these things in terms of your patient care. You have to. You absolutely have to, because it's been raised and raised more in terms of the public's consciousness. So, gadolinium-based contrast agents. European Medicines Agency has said these are the high-risk ones. So you probably want to just have a look at your department and see what they're using before you say, yes, I want you to carry out an MRA on this patient rather than the contrast, isonated contrast, because the risk is less. We'll just have a look at those agents, check what you're using. There's a middle risk, and I haven't put those ones up, but I put the low-risk ones because I think they're the ones that certainly I'd be wanting to be involved with. Dolaram, Prohance and Gadavis, they're all the trade names, not the generic names, but I put those up because they're easier to perhaps remember. So, what do they state in the Royal College of Radiology standards? EGFR less than 30 or AKI. The patient is at high risk, certainly, and the agent should be contraindicated. A high-risk agent should be contraindicated. So do not use those high-risk group of compounds in those patients. A medium or low-risk agent, so I showed you the low risk, can be used at the lowest dose possible, and they say less than 0.1 millimoles per kilogram. Do not repeat in 7 days. Avoid an AKI whilst creatinine is still rising. And if already on HD, so don't initiate it, then commence within at least 24 hours following administration. Not that there's any great evidence that helps, but if they're already on, so you've got that patient established on some dialysis, get a treatment in straight afterwards if you can. Finishing off now, just again so we can think about kidney injury and in terms of the markers we have. Creatinine is a really poor marker. It's the only marker we have apart from urine output in terms of trying to quantify what's going on. But this paper from Claudio Ronco talks about subclinical AKI due to iodine-based contrast media. And he wants us just to consider, and I think rightly so, that there is demonstration that tubular damage can occur, as evidenced by biomarkers such as NGAL, without a rise in serum creatinine. And these rises in these other biomarkers, and not creatinine, are associated with worse outcomes. So we do need to be aware that just because the creatinine isn't rising in that patient, there isn't something perhaps going on with their kidneys. For many years we've considered the kidneys as a rather forgiving organ, and I think we must consider the consequences of any kidney injury that happens to any of our patients, particularly in our more elderly population, our patients with complex disease, with multiple medications, because there's increased demands on the renal reserve. I want you just to remember this. This is my own little strap line. Kidneys are for life, and I think we need to get that across to people. Too often the kidneys have been pushed retroperitoneal to the back of our minds. They don't have the splendour of the lungs or the romance of the heart or the intelligence of the brain, but they are very, very important organs, and we really want to promote this for our patients and our other healthcare workers. And I'd just like to thank you for your attention.